The next session is Sexual Healing, Metastatic Breast Cancer, and Your Sexuality. We invite you to share your comments in the chat. Remember, if you have questions, type it in the Q&A and not in the chat. If you would like to come on screen to ask your questions, include that in your question. Now I'd like to introduce our speaker, Dr. Lauren Streicher. Dr. Streicher is a clinical professor of obstetrics and gynecology at Northwestern's University Medical School, the Feinberg School of Medicine. And she's the founder and medical director of the Northwestern Medicine Center for Sexual Medicine and the Northwestern Medical Center for Menopause in Chicago. I'm honored to welcome Dr. Streicher to the screen. Welcome. We can't hear you just yet. Unmute.
Okay.
There we go.
Oh, good. Love technology. Well, thank you for having me. I'm excited to talk with all of you. I wish I could see you, but this is the next best thing. Let me get my screen share on here so that I can show you. Here we go. Okay, I think we're good. So today we're going to be talking about sexual function, focusing on the woman who's living with a breast cancer diagnosis. And you know, for a lot of people who are listening, the first, maybe the only time that anyone talked about sexuality with them was back in 7th grade. And even if you were paying attention, and even if you do remember any of that, I can pretty much guarantee you that their focus was very different. Because back in 7th grade, what they were talking about is maybe the ability to get pregnant, how that happens, how that all works, how not to get pregnant, how not to get a sexually transmitted infection. I'm not going to be talking about any of that today. Today, what I am talking about is the ability to have a normal sexual response, which means that things happen the way you want them to happen, when you want them to happen, regardless of who or what you're having sexual activity with. Now, let's just start by saying that biologically, there's only one reason and one reason only to have sex, and that's to reproduce. And in fact, biologically, there's no purpose in sex if you're old or if you're sick. Because from a biological point of view, the purpose of having sex is to reproduce and to take care of your offspring. And if someone is very old or very sick, that's simply not going to happen. But of course, all of you out there going, whoa, 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 you know, wait a minute. Having sex is not just about reproducing. There's non-reproductive benefits of sexual activity, and you're right, there are. And in fact, when I wanted to do some research on this, I consulted some of the leading journals to find out what the non-reproductive benefits of sexual activity are. And I learned all kinds of things. Like I learned that, oh my gosh, sex prevents infection. It leads to heart health. This is my favorite. Sex prevents tooth decay. If you ever can't sleep at 2 o'clock in the morning, just Google health benefits of sex, and it's quite amazing what you will come up with. And having done these interviews, I can tell you just how creative it can be. But on a serious note, we do know that beyond reproduction, having sex, of course, feels good, and people should do things that feel good in addition to the health benefits of all those endorphins and neurotransmitters that are released. And in addition, for those that are in a partnered relationship, we know that beyond procreation, sex is going to enhance intimacy, it's going to enhance connection, it's all good stuff. And there's even people who have quantified this and talked about the fact that you can add as much as 20% value to a partnered relationship if sex is good. So those of you who tuned into Masters of Sex are, of course, experts in what normal sexual function is. But for those of you that did not, just this is the real Masters and Johnson, not nearly as glamorous. But basically, they were the first ones that looked at sexual function medically and looked at things like what is happening on a hormonal, medical, and physical point of view, from the point of getting excited to being able to have intercourse, have orgasms, and that was really the beginning of the science of human sexuality. Well, today what I'm going to do is I'm really going to simplify it and really look at the 4 components of a normal sexual response, and then we're going to look at what happens in women who are living with a cancer diagnosis. So we start with libido, and libido, of course, is the desire to want sex, thinking about sex, wanting sex. Arousal are the physical manifestations, meaning you can think about sex, but physically nothing's going to happen. Arousal in a woman is when your heart races, your respirations might pick up, nipples get hard, vaginal lubrication. And then, of course, the ability to have penetrative sex, which isn't important for everybody. But if someone would like to have penetrative sex in a normal sexual response, we look at the physical things that enable that to occur. And then, of course, if someone is lucky, they have an orgasm, which more often than not does not occur during orgasm. But these are the components of a normal sexual response that we look at. Now, when we look at this, of course, I'm focusing on the biological, the hormonal things, the physical things. There's all kinds of other things that go into this. It's just really complicated when we start to look at things like relationship, culture, the emotional aspects. And I'm not minimizing that because that's all really important, but that's not what I'm focusing on today. But the bottom line is a normal sexual response is really a balance of these excitatory factors and then putting the brakes on, because you have to put the brakes on, otherwise no one would go to work or get anything done if they were constantly having sex. So that's really what causes us to have a normal sexual response. And in order for that to happen, basically every organ system gets involved. You need to have muscles that are going to contract so that when you have an orgasm, you feel pleasure. You also have to have pelvic floor muscles that relax to allow penetrative sex. You have to have a skeletal system that allows you to get in the right positions. The neurologic system, of course, in order to feel pleasure. Hormones. I think we all appreciate how important hormones can be, and in some cases how you really don't even need hormones. And the system that's probably the most important of all is the circulatory system, because you need a good supply to get to all these areas in order to have a healthy neurologic response, healthy muscles, and of course get those hormones where they need to go. But when we look at medical conditions that impact on sexual function, it's no surprise, because when you look at all these organ systems, you see what it takes in order to have a normal response. And then we start to look at the impact of cancer on these different organ systems, because not just the cancer itself, but chemotherapy, radiation, etc., all are going to impact on the neurologic system, endocrine system, cardiovascular system. So it's no surprise that there are going to be a lot of consequences specifically from a cancer diagnosis. One of the things, of course, that people learn early on is the impact of body image concerns, whether it's losing pubic hair or hair on the head. This can have an impact on sexual response. Weight changes, either gaining weight or losing weight. Surgical scars are a huge impact, not to mention for women who go through mastectomy. The hormonal changes are not always permanent, but in some women they are, either because of chemotherapy or other drugs that are going to alter your hormones. Of course, the consequences of radiation, surgery. Antidepressants, huge. It's so important, of course, for women to have an antidepressant when they're going through a lot of the issues with cancer, but antidepressants also can have an enormous impact on the ability to have an orgasm, on libido, on sexual function overall, and then, of course, the impact of anxiety and the other medical conditions that get involved. Chemotherapy specifically, of course, can put someone into menopause, can cause neurologic changes. A lot of times they'll talk to you about the fact that you might have gastrointestinal changes or an impact on your mouth from mucous membrane changes, but they forget to mention that you can also have vaginal changes with sores, burning, dryness, irritation. The immunosuppression that occurs as a result of chemotherapy can make people more prone to vaginitis and having herpes outbreaks. And of course, the hair loss that we talked about. And then I can't overestimate the impact of fatigue. I mean, oh my God, if you are exhausted for all of these reasons that occur during the breast cancer diagnosis and treatment, when you see that pillow, you're not thinking about sex, you're thinking about trying to get some sleep. So it is no wonder with all of this going on that up to 90% of cancer patients experience sexual side effects, either transient or permanent. But let's back up a little bit, because the other thing that everyone forgets is it's not like before a cancer diagnosis, everyone was having amazing, fabulous sex. And in fact, if you look at this study of thousands of women between the ages of 18 to 100, what we find is that women just in the general population have problems. 43% of all women between the ages of 18 to 100 have problems with sexual function, and 60% of women as they go through the menopause transition, and then as women age, even more. So you put a cancer diagnosis on top of that, that's of course why the numbers are so high. So specifically, there are 4 components of sexual dysfunction that we look at, starting with libido. Libido is, I don't want to have sex, I'm not interested about sex, I don't think about sex. And libido is absolutely the #1 reason that women come in saying they're having sexual problems. The second thing that we see, of course, is impaired arousal. That's the ability to have a physical response, such as vaginal lubrication. That's the second most common thing we see. Orgasmic disorders is third on the list. Either someone who's not able to have an orgasm at all, or quite frankly, it takes so long, they just don't care anymore, they're not interested, or it's such a weak orgasm that it wasn't worth the trouble. And then, of course, painful intercourse for women who are wanting penetrative sex. And when I talk about intercourse, I'm not just talking about intercourse of the penis. Many women, of course, are having penetrative sex with a toy. So as I go forward with this talk, please be aware that I am including both penises and toys when I talk about the issues that women have with having intercourse or penetrative sex. So one of the things that's interesting is to look at what's going on in the oncology world. And this is a study that was done just a year ago that some friends of mine did, that basically they talked to oncologists specifically that were treating breast cancer. And they did a 60-minute interview to just ask them, you know, what are your attitudes about talking about sex with your patients? Do you talk about it? How important is it? And can you help them? And what they found is that the overwhelming majority of oncologists really were not able to help their patients. They really didn't think that this was very important, and they essentially didn't address it. And some of the specific comments really kind of say it all. You know, oh, it's not much of a concern, vaginal discomfort, it's just a little bit of a problem, patients don't really complain about it, it's a minor nuisance, my patients never complain, on and on and on. But of course, when we talk to patients, and I talk to patient groups all the time, certainly that is not what we are hearing. It is very much a concern. And in fact, the women that come to see us at the Center for Sexual Medicine, this is the reason that they're coming, is because it is a concern and their oncologists have not been talking to them. So let's start with poll question #1, if we could bring that up, because I'm curious in this audience, how many of you had your physicians or another healthcare provider, an advanced practice nurse or another clinician, talk to you about sexual concerns that were related to your cancer diagnosis? And I think you're all submitting now what your response is to that. And am I able to see that? Do we get those responses? Here we go. I think those responses are coming up. All right, 77% say no and 23% say yes. And you know, that's pretty much what we find in the literature. And then when we hone on down even more and talk to the people that say, you know, okay, yes, they did talk to me about it, as far as specifically what they talked about, usually, you know, they didn't necessarily say, are you having painful sex? Are you able to have an orgasm? But this is pretty typical. We have literally 3/4 of the people in this audience, their doctors never even broached the topic. So then we get to question #2. If in a perfect world, your doctors or clinicians did broach this topic, when does the audience think would be the best time to have that conversation? Is it at that first visit when you first learn that you have breast cancer and they're talking to you about treatments and the repercussions, treatments and everything else that's going on? Or is it perhaps down the road? So if we could bring that second poll question up. Or for those of you who just say it's not important at all. Initial consultation when you're done with therapy, or not important, no need to discuss it at any time. All right, and what we have here, At the initial consultation, it's the majority of you. And you know, this is so interesting because I always say when a guy is diagnosed with prostate cancer, do you think that maybe at that first visit they might mention that he's going to have an erectile dysfunction, he's going to have sexual problems? You bet, 100% of the time. And there's this disparity between what we see for the men and the women. So we have a problem here, and I'm very solution oriented. So what I'm going to do now going forward is, instead of just talking about the problems, because you all know that the problems exist, you all know that your doctors haven't been talking to you about it, and I'm going to talk about the fact that there are solutions for virtually every single category of problem that we've talked about. So what I'd like to start with is painful sex. And this is really what I'm going to focus on, because when I look at the reason that most women come to the center, it really comes down to painful sex. Even women that walk in the door and say that their issue is libido and they don't want to have sex, and I'll say, well, when was the last time you had sex? 3 weeks ago. How did it go? Well, it hurt like hell. Well, your vagina's not stupid, and if it hurts like hell, you're not going to want to do it. So our approach is always fix the pain, and then we circle back and take a look and see how your libido is doing. So when we look at painful intercourse, there's a lot of reasons why this can occur. And our first job, of course, is to find out why. We never assume anything. We always have to do a very careful history and an exam to see if this is a result of menopause. Is it from chemotherapy? Is it from radiation for people who have pelvic radiation, who also have ovarian issues? So we do the deep dive to find out what's going on. But in most cases in breast cancer, the number one reason that women have the onset of painful intercourse is because thinning and drying of the vaginal tissues as a result of the hormonal changes that occur either because of menopause or because of the medications that you're taking. So when we look at things that cause vaginal dryness in a cancer diagnosis, yes, menopause, chemotherapy, and then for a lot of people, medications and vascular problems. Now, most women, when they have these problems, the first thing they're going to do is they're going to head on down to their own medicine cabinet and see what they have. And most people, they go for the baby oil because they feel like, okay, it's good for the baby's bottom, why not for my bottom? It's kind of slippery. It might help things along. And it's actually not the way you want to go unless in a pinch. Because number one, for those women who are not in a monogamous relationship, it's not condom compatible. So that's the problem with any of the oil-based solutions. But also it increases yeast infection. And Vaseline, which is another go-to for a lot of women, good for your lips on your face, not good for the lips on your vulva. It is not condom compatible and actually doubles the risk of bacterial vaginosis. Likewise, when you head on down to the kitchen to see what you can find there that's slippery, same issues. All of these oil products, coconut oil, all that, seems like it's a good idea, but they don't work that well, they don't last very long, and they do increase the risk of vaginal infections. So by the time you head to the pharmacy, it's quite honestly, it's confusing. There's rows and rows of all kinds of stuff. Most people grab the first thing they find because they don't want to see anybody they know, and then they just get out of there and get home, and very often find that they're disappointed. And the reason is because these products, lubricants, are not all created equal. And it's, again, confusing because there's two categories of products that you're going to find. You're going to find lubricants that are used during sexual activity that essentially make things more slippery. They decrease friction. You have to apply them at the time of sexual activity, versus a vaginal moisturizer that's put on a regular basis in order to increase your natural lubrication, but not to be used at the time of intercourse. Two separate products on the same shelf to be used differently, different purposes. When it comes to moisturizers, it also gets really confusing because of the marketing issues. What we know is that a lot of times for marketing purposes, products that are actually lubricants are labeled as moisturizers. And why? It's because nice women use moisturizers on their face and on their vaginas, but not nice women, hussies and sluts, use lubricants. So as a marketing ploy, they label a lot of lubricants moisturizers to make women feel more comfortable. Basically, there are two groups of moisturizers that are actually moisturizers and actually work. One is Replens. These are over-the-counter, non-hormonal. Replens long-acting moisturizer, and then the hyaluronic acid moisturizers that need to be applied on a regular basis 2 to 3 times a week. Lubricants, on the other hand, are to be used at the time that you have intercourse. Most people go for the water-based lubricants first, and they have the advantage that they're readily available, they're inexpensive, you can use it with your toy, you can use it with condoms. The disadvantage is a lot of these water-based lubricants don't work very well. They don't last very long, they're kind of sticky, and because of the preservatives, there's actually a real problem in terms of causing damage to the vaginal tissue. So when you choose a water-based lubricant, you really need to know what you're choosing. You can't just grab any lubricant. And I'm going to talk for a minute about osmolality. And I'm not going to get all sciencey on you because we don't have the time, quite frankly. But osmolality is important. Now, this is basically the concentration of a product. And the osmolality in the vagina is 300. Keep that number in mind, 300. So any product that you put in the vagina, you want to be in that neighborhood, because if something has a high osmolality, it's actually going to dehydrate the tissue. It's going to break it down. It's going to cause genital burning and itching and everything that you don't want to happen. So keeping the number in mind that you want it to be around 300, anything less than about 1,200 is considered to be acceptable. KY warming jelly, 10,000. 10,000, oh my God, poison to the vagina. Even regular old KY jelly is over 2,000, Astroglide. All these popular water-based lubes actually cause vaginal damage. They cause the tissue to dehydrate and be broken down. There are good lubricants that you can use that are low, that are not going to cause damage. All this stuff is on my website, by the way, so if I know I go fast. Every single thing here that I'm talking about is in detail on drstreicher.com with all these lubricants, all this information I'm giving you explained in even more detail, because I do tend to race through this stuff when I'm talking to a group. But the other thing you need to know about is the silicone lubricants. There's the water-based we were just talking about. Silicone lubricants don't have these osmolality issues. They don't damage the tissue. They last longer. They're more slippery. They're not irritating. The disadvantage, a little more expensive. You're worth it. They have to look for them. I'll tell you where to go to find them on my website. You can't use them with toys. But other than that, the silicone lubricants generally are better. But beware, if you have sex in the shower, if it falls on the floor, super slippery. You don't want to call the paramedics on that one. So beware with the silicone lubricants. They are a little bit accident prone. Now, for a lot of women, you can use a bucket of lube and it's not going to help you, because lubricants at the end of the day do not change the tissue. They make it more slippery. They decrease friction. And it's the prescription products that actually change the tissue. So when we look at these prescription products, we have a very long list of both estrogen-based products and non-estrogen-based products. And we have one goal in mind. This is a biopsy of a healthy vagina. This is how it looks like, this nice, thick purple areas where all the lubrication comes from. This is what it looks like when you don't have any estrogen, when you don't have any lubrication around. You get thin like this, and what we're trying to do is go from here to here, and all of these products do it, and we have a lot of them, and I'm not going to go through them in the interest of time, again, all on my website, but we have both estrogen and non-estrogen products that will restore natural lubrication and elasticity to ensure pain-free intercourse. I'm not going to get into the whole safety of estrogen thing, because that's takes a whole nother lecture, other than I'm going to give you the short version, which is it is safe for women with a breast cancer diagnosis to use vaginal estrogen. It is absolutely safe. This has been well studied. And in fact, I always like to show, this is a study I did that was published a few years ago, that I actually polled board certified OB-GYNs, and I said, if you personally had breast cancer, would you use vaginal estrogen? And guess what? Close to about 97% of them said, oh yeah, I would use vaginal estrogen. So it is safe, but having said that, I know a lot of you don't want to even be in the same room with estrogen, and your doctors have told you not to use estrogen, and despite my reassurances or any other doctor's reassurances, you're just not going to go there. So we do have a lot of non-estrogen products, but one of our favorite things that we like to offer that I'm going to talk about for a minute is the Mona Lisa Touch CO2 laser. And yeah, vaginal laser is a real thing. This is something that we have a very huge program at Northwestern. And basically, vaginal laser is a non-hormonal, non-medication way to alleviate vaginal dryness and thinning of the tissue, not just for women that are having painful intercourse, but for women that are having urinary symptoms, that urgency, recurrent urinary tract infections, itching, irritation, and we are both able to treat vaginal and vulvar tissues. So this is 3 in-office treatments at a 6-week interval, and we treat both the outside of the vulva and the opening to the vagina, which is where a lot of women have their big problem, and then we put a probe inside the vagina and we treat the entire inside. It takes about 5 minutes. There's no pain. You don't need any anesthesia other than we use a local cream on the outside. And the way that it works is the laser penetrates the vaginal tissue about half the thickness of a dime. It's really very minimal. And by doing that, it actually kicks your own body into action to form new collagen, increasing blood supply and thicken the tissue to resurface the vagina so that you go from here to here. And in fact, we find that about 95% of women in our laser program have restoration of normal lubrication and elasticity. You do need to have an annual booster. You still need to use a lubricant, but here's the rub. Insurance does not cover the procedure. It's about $3,000 at Northwestern. Insurance doesn't cover it. It will never cover it. But before you get all upset about this, I have great news for everybody, because we have a program at Northwestern, which I initiated about a year ago, called the BRAVA program, Breast Cancer Vaginal Health Access. And through the generosity of donors and working with Northwestern Foundation, yeah, we're giving free laser treatments away to women who have a breast cancer diagnosis. We're very excited about this program. As I said, we launched it a while ago. Any woman with a cancer diagnosis is eligible. The criteria beyond having a cancer diagnosis and being in menopause is that you need to have the symptoms of what we call genitourinary syndrome of menopause, the thinning and drying of the tissue. We see you in the Northwestern Medicine Center for Sexual Medicine and Menopause to evaluate you, to see make sure you're a good candidate, to make sure that there's not any other reason that you're having vaginal pain and vaginal dryness. And then, of course, an inability to pay out of pocket for the CO2 laser treatments. And of course, for those of you who are out there who do have the ability, we'd also encourage you to donate to help those women who are not able to participate without this program. So if you're interested, you go to sexmedmenopause.nm.org/brava-program, where you can apply, fill out an application, be seen in the center, and we have laser to give away. So please log on, and we are happy to get you in, evaluate you, and see if you are a candidate for the BRAVA program. So I'd like to go now to poll question number 3. And that's, are you even aware that there are doctors that treat this stuff, that treat women that have sexual pain, the inability to have an orgasm, the inability to have a decent libido as a result of cancer or cancer treatments? How many of you were aware before this talk that that was something that even existed? And the poll is, yeah, again, most of you are not aware, because, and I complain about this all the time. I talk to oncologists and I beg them to give our brochures, to tell women that they don't have to talk about themselves, just send them our way. And for a variety of reasons, we are not getting the oncologist to refer. And in fact, we are finding that most women that come to our center are in fact self-referred. From hearing about it from a friend, or maybe hearing me talk someplace. So I want to finish up by spending a few minutes talking about the Northwestern Medicine Center for Sexual Medicine and Menopause, which I started, it's been about 3 years ago now. They specifically hired me to start this center. And basically, they love coming here. It's warm, it's welcoming. We start with a pre-screen to make sure that you're a good candidate. We don't do general gynecology here. We have specific programs for women who are having these issues as a result of cancer, and of course other problems too. We see women with diabetes, heart disease. We see all ages starting. We have women as young as 18 that come to the program. And yes, we have had women in their 90s who come to see us at the Center for Sexual Medicine. This is the beauty of what we do here is it's collaborative. We have an extraordinary team made up of physicians, nurse practitioners, physician assistants, pelvic floor physical therapists, sex therapists. And we keep growing. We've just hired a vulvar specialist who's going to be coming in. It's really an extraordinary group of women who collaboratively work together to help women with these issues. I do want to say a word about sex therapy because that kind of freaks people out when we talk about sex therapy. No, sex therapy is not watching you have sex. Has nothing to do with taking your clothes off. Sex therapy is talk therapy. Our sex therapists are amazing therapists who have at least a master's or a PhD in therapy, and then go back, do additional training and understanding all of these sexual problems and concerns that women have, so that if you walk in the door and say, I have, chemotherapy and my vaginal tissues are raw and irritated and dry, they know exactly what that is. They know exactly how to help you with that. But unlike us, they're dealing with communicating with your partner, dealing with desire discrepancy, reigniting sexuality that has been on hiatus for a long time, coping with the pain, coping with things that are different. And one of the things I love about our sex therapists is they're really good about looking at the new normal, because we know that for a lot of women, either temporarily or sometimes even permanently, that having penetrative sex is just off the table. So they will introduce a lot of other things that maybe you don't know as much about, that will kind of perk up your sex life again to get you back thinking about intimacy and your own sexual pleasure. I do have a book called Sex RX, Hormones, Health, and Your Best Sex Ever, which specifically has a chapter on sexuality after cancer and really does the deep dive on the impact of chemotherapy. There is a section specifically about breast cancer, because obviously in this short time, I've only been able to touch on a couple of little things, and it's a very big topic. So I do encourage you to take a look at that, and also to go to my website, drstreicher.com, where I have many, many articles about this. But most important is I want you to come see us at the Northwestern Medicine Center for Sexual Medicine and Menopause. We do our virtual appointments for those of you that are out of town. We have many programs. In addition to our program for sexual medicine, we have specifically a program for menopause, including chemotherapy-induced menopause. We have a very robust program for vulvar and vaginal health for women who have vulvar, which is the external genitalia problems. We have a wonderful program for bone health and osteoporosis. And then, of course, our Brava program to offer complementary laser treatments for women with a breast cancer diagnosis. So we have so much, and we're always adding new programs and taking everyone's suggestions what we should do. So at this point, I think I am out of time for talking, and we're going to open it up for some questions.
Yes, and we have some questions ready for you. Thank you again for such a great, insightful conversation. The chat box was lighting up. There's a lot of rich conversation happening. Yes, so question one, I'm on Faslodex and Ibrance, which cause dryness and painful, almost intolerable intercourse. I did the Mona Lisa and it helped a bit, but still painful. My sex drive is so low.
Right.
Any ideas?
Yes. So we actually see this a fair amount. Women that come in and either they've had a Mona Lisa treatment or maybe they've used something else and they're still having pain. And of course, in this person's situation, I don't know for certain, but for many of these women, the reason is that they're having pelvic floor muscle problems, because what happens, I mentioned, if someone is having painful intercourse for whatever reason, their vagina is going to shut down. Those muscles are going to contract. And then even when we treat the tissue and it's no longer dry, your pelvic floor muscles don't know that. We have to erase the muscle memory. So very often when we have someone who's had a Mona Lisa treatment, if they're still not better, first of all, I get them in and reevaluate the tissue. We talk about the standard 3 treatments. Quite frankly, I have patients with breast cancer that I need to do a 4th treatment, that I need to do some pelvic floor physical therapy. I might need to do some dilator therapy. The point is that we don't end with that. If someone's, our whole mantra is, we're going to do this therapy, and if you are still having pain, that is not okay. Come back, we're going to reevaluate you, and we're going to, look into our bag of tricks and see what else we can offer. Because we know that those treatments are not necessarily going to work as a solo treatment, that other things are needed as well.
Okay, well, thank you. You actually answered the next question that was asking about whether or not Mona Lisa was the only option. So I was glad to know that there's a spectrum and there's
I
other
just like to
opportunities.
add on that because, I was talking about Mona Lisa a little bit more today than I normally do because I wanted everyone to know about the Brava program that I'm really excited about. But the truth is that we have many, many options. And as I mentioned, even though local vaginal estrogen is safe for women with breast cancer, we appreciate that a lot of women are not going to go there. And we have a lot of non-hormonal things that we offer that, quite frankly, a lot of the other doctors out there, and that's the problem, is a lot of women, they might have a wonderful gynecologist who's really good and they really trust, but quite frankly, is not an expert in this. And that's why we don't do general gynecology. We expect women to continue to see their general gynecologist, but we will address specifically those issues because we have a level of expertise and we know about other treatments that their own gynecologist may not know about.
Okay, fair enough. So another question, with vaginal atrophy, there we go. With vaginal atrophy, I've heard that you need to use your vaginal muscles or lose them. What do you recommend for those of us who don't have regular partners? Are there exercises we should be doing or toys that we can use to help us?
All right, so this is the deal. We've all heard the expression, use it or lose it. My expression is different. My expression is fix it and then use it or lose it. Because a lot of women, they're having pain and they're like, okay, that's because I'm not doing anything. And then they try and have sex or they try and use the toy and it's excruciatingly painful. And then they keep doing it because they think that's going to be the solution. So first we fix it to get you to a pain-free point. And then yes, if you do not have a flesh and blood partner, you should be putting something in the vagina in order to keep those vaginal tissues elastic and lubricated. And yes, we do recommend that you use a toy. And if you go to drstreicher.com, go to Vibrators 101, and it will show you the nitty-gritty of what kinds of toys, because most women use toys for external stimulation because that's how women have orgasms, is from clitoral stimulation and external stimulation. They don't have orgasms for the most part, maybe only 15-20% from vaginal penetration. So that's what happens, is a lot of women who don't have a partner and they're self-stimulating and self-pleasuring externally and they're not putting something inside. So that's where that rabbit vibrator comes into play. That's where a dildo comes into play. And yes, it is important to keep those tissues healthy and elastic for your own pleasure. And then also if you do happen to have a male partner at some point.
Okay. So we have one more question. Would you recommend using CBD lube or other topical treatments than what you
Okay, this is a hot topic, and certainly that's something that we are asked a lot and we talk about a lot. There are no studies, zero, none, no data. Having said that, anecdotally, we do know that CBD is a vasodilator, meaning it dilates blood vessels and it increases blood flow. Increasing blood flow is a beautiful thing. In order to have decent lubrication, you need to have decent blood flow. In order to have nerves that are going to feel sensations, you need to have decent blood flow. So do I tell my patients to use CBD oil? I do. Do I have the data to back it up? I do not. And I hope one day we do. We're actually talking about doing a study with that, but I don't think there's any harm in it. And I think for a lot of women, that may be something that will enhance their sexual pleasure.
Okay, well, sounds good. This concludes our session with Dr. Streicher. Thank you again for your time today and for this very insightful presentation.
Thank you for having me.